Hello, I'm Dr. Patrick Hwu, CEO of Moffitt Cancer Center. We're here at the 2024 SITC annual meeting, and I'm honored to have Dr. Ahmad Tarhini here, who is a melanoma expert at Moffitt and a great investigator. So, Ahmad, thanks so much for being here with us.
Thank you, Patrick.
Yeah. So tell us what's going on in the melanoma field and what's the most exciting work that you're seeing right now.
So the most recent advances that we're excited about are in the area of neoadjuvant therapy of melanoma. We've seen great advances happening there, but obviously there are a lot of open questions where we're investing in research, both at Moffitt and at a national level. So in terms of neoadjuvant therapy, what is the optimal regimen to treat patients with local regionally advanced disease pre-operatively before we do the surgery? We have exciting data from the S1801 study testing pembrolizumab. We also have even more exciting data with combination ipilimumab, nivolumab in this patient population. Obviously, as we do combination, we see higher response rates, higher pathologic responses, but also more toxicity. We recently reported our effort at Moffitt in an investigator-initiated study that was published at Clinical Cancer Research just last week, where we tested combination anti-PD-1, systemic anti-PD-1, plus intratumoral administration of plasmid IL-12 through electrogene transfer. That was an exciting data as well in terms of minimizing systemic toxicity, but also maximizing the pathologic response. We've seen 60% of these patients had a pathologic complete response, 80% had a major pathologic response. So obviously there are different combinations. The question how to optimize, and this opens up the era of or the questions of biomarkers. Can we use predictive biomarkers that can allow us to treat those who have the capacity to respond from specific treatments, let's say monotherapy, and minimize toxicity, minimize cost for these patients? There are interesting insights looking into PD-L1 expression, CD8 T-cell infiltration, tumor mutational burden, interferon gamma gene expression signatures, etc. We are interested in bringing all those together, try to zoom in on those patients who probably should be saved combinations, only treated with monotherapy. In our CCR paper, for example, we demonstrated that this combination can achieve PCRs in patients who are CD8 low, PD-L1 negative, interferon gamma expression negative as well. So we probably should be investing in such combinations only in those patients who are unlikely to respond to PD-1 as monotherapy.
Well, very exciting. So what you're saying is that more and more data in the melanoma field shows that if you have a tumor in place, you should treat with immunotherapy before you even cut it out. And we still have to figure out the mechanisms of why that's a good thing, but not only combinations of immunotherapies systemically we have to think about, but your paper was showing that if you intratumorally express IL-12 in the microenvironment, plus anti-PD-1, that could even be more powerful.
True.
Yeah.
There are interesting insights there as to why mechanistically neoadjuvant therapy works. There is data which demonstrated that we can actually have a more significant expansion of tumor-resident and tumor-specific CD8 T-cell clones in the periphery, in the neoadjuvant setting, as compared to the same treatment in the adjuvant setting.
And when you cut out the tumor, you're not only taking away the antigen, but you're taking away all those T cells that are proliferated at the tumor site.
Absolutely.
Yeah.
Great.
Well, it's really exciting times in the field of melanoma and neoadjuvant therapy, and what we can learn in melanoma, we can take to other kinds of cancers too, right?
Exactly. And this is, we had a position paper recently published in JITC as well, where we've, suggesting certain guidelines as to how we can expand this approach across many other solid tumors, and suggesting different, ways of clinical trial design, the endpoints, the duration of the neoadjuvant phase, the indication to use adjuvant therapy or not. So this was an interesting position paper I think would be helpful as well in this regard.
Well, thanks for being with us here today to talk about neoadjuvant therapy and biomarkers.
Thank you. My pleasure, Patty.